Okay, so any questions that you may have, please ask. Please stop me and ask so that I know that you're not sleeping or you're not watching something on Netflix while the lecture is going on, etc., because some strange things have been happening. And we see that when we do the oral exams at the end of the rotation. So we know the persons who are engaged, because I'm going to tell you here and now that the questions that we ask are very simple questions because we know that you are not ophthalmologists. So if you were paying attention any at all, you'd be able to answer the questions because we don't ask difficult questions in the oral exams. Okay? So that being said, we're going to go forward, and you all know what the lecture is before. So I'm going to hope that you actually did some reading before so you would at least have some idea. As I said before, sickle cell is not terribly difficult because you have met it before. Okay, so we're going to look at sickle cell. I'm going to share a window here. All right, so this is what we're going to be talking about. And just to give you a little outline, we're just going to talk about sickle hemoglobinopathies, and we're going to go straight into the ocular manifestations. And we're going to talk a little bit about the management, including the treatment. But I tell you here and now, folks, we're not going to be asking you how to treat sickle cell. You're going to be getting an overview because we want you to be safe doctors. So please don't spend your time trying to figure out how we treat sickle cell. This is a lecture to guide you because if we're talking about sickle retinopathy, we want to mention the treatment. Remember, when you decide to specialize in ophthalmology, then we can go into that sort of detail, but you want a good overview. So, let me clear my throat. The hemoglobinopathies are a group of hereditary disorders, and they're characterized by abnormal hemoglobin formation. And this first part is really just a refresher's course. So you know that there is the hemoglobin molecule, and it consists of 2 alpha peptide chains and 2 beta polypeptide chains. And there is an amino acid substitution, and this is a point mutation. This is one of the very few. If I'm not, if I remember correctly, I think this was the first one, but don't quote me on that. But there is an amino acid substitution at position 6 on the beta chain. So for hemoglobin S, glutamic acid is replaced by valine. And in the abnormal hemoglobin C, glutamic acid is replaced by lysine. Okay, so here we have our sickle hemoglobinopathies now. And so these are the abnormal hemoglobins, and they may occur in combination with normal hemoglobin A, or in association with each other, as I have outlined here, as I said. So we have SS, which is sickle cell disease. So there are 2 sickle cell genes, one from each parent. Then you can have SC, sickle cell C disease, 1 sickle cell gene from one parent, and then the abnormal hemoglobin C from the other parent. Then there's sickle beta thalassemia, where there's 1 sickle cell gene from one parent and 1 gene for beta thalassemia, which comes from the other parent. And then, sorry, we have the sickle cell trait, where you have 1 sickle gene S from one parent and 1 normal gene hemoglobin A from the other parent. Now, don't ask me about CC. I've never Heard about it? So I suppose it is possible, but maybe it is so rare. So don't ask me about CC disease. We have SS and we have SC. Um, okay. And all of that is just refreshing your memories. Now, just to go on about our sickle cell disease, a reminder of sickle cell anemia. And it affects about 0.4% of Black Americans, and it is an autosomal recessive condition. And as I mentioned before, it's a point mutation. And here we are just repeating what we just said. Okay, so valine replaces glutamic acid. Um, and I even give you some more information. Chromosome 11 is where you have the beta globulin gene. And so sometimes you may see something like this in the multiple choice when we want to get very specific. I don't know what is in your multiple choice. I don't set the paper. But certainly, these are some of the fine print that you may be asked in the multiple choice. And so sickle cell disease is characterized by severe chronic hemolytic anemia, as you all know. And ocular complications are usually mild and asymptomatic. Then we look at our SC disease, and it is present, of course, it is less frequent, about 0.2% of Black Americans, and it is characterized by hemolytic anemia and infarct crises that are much less severe than in your SS, sickle cell disease. But it is associated with severe retinopathy. Or sickle cell beta thalassemia, it comes with a very mild anemia, but this too may be associated with severe retinopathy. So your systemic complications are mild, but you can have severe retinopathy in your sickle beta thalassemia. And our sickle cell trait is present in about 10% of Black Americans, and it is the mildest form, actually. And you're usually normal because some patients go through life and don't know that they have the trait. And so it requires severe hypoxia or other abnormal conditions to produce sickling. So unless you're subjected to some, abnormal condition, you may not know you have it. So they don't have symptoms of sickle cell disorders except they get pain when your oxygen is less than usual, much less than it was. For example, scuba diving and activities of very high altitude, and sometimes under general anesthesia. So that is why sometimes you need to know what your sickle status is when you're going under general anesthesia, because unless you're really stressed, you will not manifest any signs of sickle cell for the trait. Now, as it speaks to our Jamaican condition, it is very similar to what we see in Black America, of course, because we're all coming out of Africa. And in Jamaica, we have approximately 10% that carry the sickle cell gene. And Prof. Sargent, he was instrumental. He has died now, and he did a lot of research on sickle cell, because if you want to know about sickle cell, papers and papers have been written, and it's coming right out of Jamaica. And so we in Jamaica, we know a lot about sickle cell. And as I mentioned before, when I spoke to the oral exam, just a little, well, anecdote, if you will, or a little tip when you do oral exams. When you do oral exams, there's a very good technique to oral exams. And I had a colleague who um, went to the UK and did the ophthalmology exam in the United Kingdom. And so he was asked something about sickle cell. Now, I'm not quite sure if he steered the conversation into sickle cell or he was asked something specific about sickle cell. And he was very happy because he knew about sickle cell. He knew about sickle cell retinopathy. And those guys there, they don't know. So he sat down and he took over the Bible, oral exam, and he spoke about sickle cell disease and all that he knew. And they all sat down and took notice. And that is a little guide for you. If you know something, you can take over the conversation and you can discuss it. And obviously, you're going to discuss it with some authority. And so he spent the time and he gave them a good lecture on sickle cell disease. And of course, he passed with flying colors because they don't know. I guarantee you, they don't know. So, just a little tip when you know something, you want to go to town and discuss it, if you will, and you can steer the conversation in the direction that you know, and you can do very well. Now, on the flip side of that, you can say things that you can steer yourself down the rabbit hole and be in some serious situations. So you don't want to say things about which you do not know. And it's very important. Do not discuss things that you don't know about because you're going to be asked. Okay? And so this doctor did extremely well because he knew all about sickle cell, he spoke with authority, and he knew about sickle cell retinopathy. Anyway, I digress a little bit. So we have for sickle cell disease, about 0.3% of Jamaicans have sickle cell anemia. Now, as I speak to SC and sickle beta thal, I couldn't find figures for those, but I know it probably is similar to what the US data is showing because it's very uncommon. Not sickle SC is probably about 0.2%, and beta thal, I'm not, but I certainly think it's similar to the US epidemiological quotations. So what happens with sickle red blood cells? So as you all know, the normal red blood cells are soft and flexible, and they mold and pass through your blood vessels because they're very flexible. Now, in sickle cell disease, the red blood cells can change from round to half moon when it is deoxygenated. So when you're under stress, deoxygenation, it changes, and they become hard and inflexible, and they plug up small blood vessels because they cannot mold and pass through, squeeze themselves up and pass through. They just clog up the vessels. So what happens here? It causes the blood and oxygen to be slowed down or stopped, and which in turn leads to hypoxia and multiple organ damage. Hence, you have your crises. So, I'm sorry here. Deoxygenation, it leads to hydrophobic interaction between the adjacent sickle cell molecules and the distortion of the red blood cells into that sickle moon shape. And so they're very fragile and they hemolyze rapidly. Okay? And their lifespan is markedly reduced down between 10 and 20 days. As you know, the normal lifespan of your red blood cell is. What's the normal lifespan of the normal red blood cell, people?
120 days.
Thank you. Oh, you're there. Thank you, Doc. Thank you very much. Thank you very much. And so, right, so you get clogging of the red blood cells in the microcirculation. Of course, in your little arterioles and so on, it's going to get clogged up. So here we have our normal red blood cell, which has that kind of umbilicated dimple form like a donut. And then we have our sickled red blood cell. Okay, so what do we see in these patients who have sickle cell hemoglobinopathies? How does it affect our eyes? Now, as I said before, the most important genotypes with regard to ophthalmic manifestations are your SC and your sickle beta thalassemia. So about 33% of these patients have sickle retinopathy for your SC, and in your sickle beta thals, about 14% of these patients have proliferative sickle retinopathy. Now, it's not very sure why that is. But I saw recently where one of the postulates is that the severity of the retinopathy, as opposed to your sickle cell disease, is that there is better circulatory capability of the red blood cells with hemoglobin, SC, and sickle beta thal to allow for continued flow within the neovascular lesion. So we're gonna see these new vessels, if you will. And what this is saying is that there is still some amount of flow with your SC and your sickle beta thal in these lesions. Whereas in SS disease, the peripheral vasculature is more completely occluded. And so you don't get the development of as much proliferative lesions. So you don't get as much bleeding from these vessels and so on, because you are still perfusing, if you will, some of these new abnormal lesions that are formed, which I'm going to talk about shortly. And this is one of the theories, but it's not known for sure. But that's one of the postulates. So what do we see? And sickle cell, it can affect every part of the eye. You can get the orbit being affected. You can get the anterior segment being affected. Okay, we're going to specifically look at the posterior segment, specifically the retinopathies, where we get non-proliferative and we have proliferative. And you just had your lecture this morning, and I'm glad you had your lecture on diabetic retinopathy, because it's kind of similar in a sense, because the pathophysiology is going to be more or less the same, where you have new vessel formation and you have um, vascular occlusion. And other manifestations are central retinal artery occlusion and central retinal vein occlusion. These are rare, but they do occur. So in the anterior segment, it includes segmentation or corkscrew conjunctival vessels. And they have a kind of comma shape, and they are more commonly seen in the inferior bulbar conjunctiva. So you pull the lower lid down, and you see these are the common looking vessels. I couldn't find any online that was suitable for demonstration, but they look like a comma, and that's what they look like. There's iris infarct and atrophy. And so when you look at patients at some of the irides, and I probably should put a photograph of it, it's you see patches where there is atrophy of the iris. Of course, they get cataract. Of course, they get phthisis bulbi, where they get shrinking of the eye, eventually from other complications. And as I show you here, they also get a hyphema, which is blood in the anterior chamber. And I'll speak to that just a little bit more, because this is one of the situations in which patients who are AS, who have the sickle cell trait, they can get very serious eye complications, just like patients with SS or SC, because the anterior chamber is a closed system and you get less oxygen in this system if you are AS, and you can get sickling of your cells in the anterior chamber, which clogs up your trabecular meshwork and lead to a glaucoma. So AS patients are those who can just as bad complications as our SS and SC patients when they get a hyphema. So when we look at the retinopathy now, Mr. Goldberg classified it. And this is, well, any book you open, you see the 5 stages of the Goldberg classification. And so in the Goldberg classification, we have stage 1, where there's peripheral arteriolar occlusions. Stage 2, where you have peripheral arteriovenous anastomoses. And in stage 3, there's neovascular and fibrous proliferations. We call them the CFAN. Stage 4, you get the complication of a vitreous hemorrhage, and stage 5, there's a retinal detachment. So this is well known, well written, and these are the stages. So in our stages 1 and 2, where we have occlusion and arteriolar anastomoses, these are occurring in the peripheral retina. And because it's in the peripheral retina, it's not associated with vision loss. If you remember your lecture this morning, I'm sure you do, with our diabetic retinopathies, it tends to be more mid-periphery rather than peripheral. And that's the difference. So sometimes we see patients and we can tell that these patients are sicklers because of the location of the hemorrhages. Okay? And so we have here a salmon patch hemorrhage. This is what it looks like. And they're superficial intraretinal hemorrhage. And they are usually adjacent to the retinal arteriole. And then there's the black sunburst, which is what this is. And we see it all the time. We see a patient, and the patient comes in, and you look in the dilated fundus, and you see this, and you say, do you have sickle cell disease? Because just looking at the retina alone, you can tell that this is a lesion of sickle cell. So what happens in our just the progression of these? So when an arteriole becomes clogged or occluded by a plug of sickled erythrocytes, you can get a hemorrhage. And this hemorrhage presumably occurs from ischemic necrosis of the blood vessel wall. Okay, and so this is what it looks like. It's round or oval and bright red. Okay, and so in the days or weeks, a modification of this color occurs that it just contrasts with the dark color of the RPE. And this area is known to be, it takes on a salmon patch or salmon colored appearance. And this is why we call it a salmon patch. So it's really, you have necrosis and then there's hemorrhage around it. And it takes on that salmon patch color. Now, when the hemorrhage occurs in the outer retinal layers, it stimulates the proliferation of the RPE. The RPE is the retinal pigment epithelium. So that is why I tell you that it stimulates RPE hyperplasia, because it stimulates the proliferation, because it's pigmented, of course, because it's a retinal pigment epithelium, and so it stimulates proliferation. And this leads to the formation of a dark oval or round chorioretinal lesion. And so it is similar in appearance to what we call a chorioretinal scar. So you have chorioretinal scars for different reasons, but it looks just like a chorioretinal scar, and we call this a black sunburst. So this lesion is occurring in the outer retinal layer, okay, and it stimulates the RPE, whereas your salmon patch hemorrhage is occurring in your blood vessel wall itself. Okay? Now, here we have our stage 3, which is our proliferative now retinopathy. So, and this is what we call our C-fan neovascularization. And it looks just like a fan. So here, this photograph is with fluorescein angiography. You inject fluorescein into the bloodstream, and when you take photographs, fluoresces, and you take photographs, and this is what it looks like. So you see an outline of this we call our C-fan neovascularization. So this is our Goldberg stage 3. Okay, so what happens here? This new vessel formation, it occurs at the junction of the vascular and avascular retina. And as I said, it resembles a fan. And initially, this CFAN can be fed by a single arteriole and draining vessel. And later on, this CFAN grows in size. And when it grows in size, it becomes difficult to distinguish the major feeding vessel and the draining vessel. And so this CFAN may acquire a glial and fibrotic tissue envelope. So it just kind of walls off onto itself. And when this happens, it can pull the vitreous, and it pulls on the vitreous and can result in a break in the retina, a retinal tear. So it acts like a scaffold and it pulls on it. So it's like you're pulling on your clothes because it shrinks and it starts to pull. And this may lead to a regmatogenous, which is a retinal detachment. Regmatogenous means a tear. And so if the retina is torn, you get a regmatogenous retinal detachment. So you have here that CFAN and it can pull. Sometimes it doesn't tear the retina, but it pulls on it. And when it pulls on it, we call it a tractional retinal detachment. So this is our stage 3 where you get the CFAN neovascularization. And so now stages 4 and 5 of our Goldberg classification, we have vitreous hemorrhage. And so when we have uncontrolled proliferation, you're going to get bleeding because these vessels are very fragile and they bleed. And so you get vitreous hemorrhage. And so your vitreous hemorrhage can take many forms. You can get a total vitreous hemorrhage where it looks like, you stir up some ketchup in a glass. And or you can get this pre-retinal hemorrhage where it leaks and it's pre-retinal space, you get this collection. So you see here, we have new vessels. So here you have a cottonwool spot, and you have this hemorrhage here. And this hemorrhage, depending on where it is, can cause significant vision-threatening complications. Okay, I saw a patient, she came in with a total hemorrhage where she just couldn't see anything. Here, if this hemorrhage is located close to your macula, you're going to be in problems. If it is outside away from your macula, you're going to have less problems. And here we see this kind of traction occurring. You're not able to appreciate the traction because of this, anterior posterior view, but you get tractional detachment, you get scar formation and pulling of the retina, and the retina can tear. And so this is what you get in stage. Other complications of our sickle cell, which is rare, we have central retinal artery occlusion, and you can also get central retinal vein occlusion from sickle cell disease. And basically that is self-explanatory because what is happening now, this occlusion, instead of occurring in our small arterioles, this is occurring in our larger vessels. Okay, so here is in our large artery, our central retinal artery, or the central retinal vein. So you will get occlusion there. So what do we have as the symptoms of sickle cell disease? In the early stage of disease, and certainly in our salmon patch and our black sunburst, tends to be asymptomatic. You don't know, you're seeing very well, and unless you do a dilated fundoscopy, you don't see these lesions because, as I mentioned before, they are further in the periphery and they don't obstruct your visual axis to any extent. Patients may have some amount of floaters. You may have a hemorrhage in the periphery and you start to see little floaters, blood floating down. Or you may have photopsia. Photopsia, let me see what it's kind of early. Photopsia is flashing lights. That is what photopsia is. And we like when you use a jargon because you sound intelligent when you use a jargon. But if you don't remember the word and you say flashing lights, that is fine. But what I don't want you to do is to use words, you don't pronounce it correctly, it shows that you don't understand. So I would rather you say patients may have flashes of light as opposed to try to say photopsia and you cannot say the word photopsia. For example, in the exam, I heard students talking about pterygium, and that was not sounding very good to me. And you drop a notch or two when you talk about a pterygium. So you need to pronounce the words. It is a pterygium. The P is silent. So whenever you're pronouncing, there are a lot of words in ophthalmology that may be new to you. And just take my advice, learn to pronounce them and pronounce them correctly. Some words you cannot get away from. You can get away from saying photopsia because you can say flashing lights. You cannot get away from talking about a pterygium. Okay? So you've got to learn to pronounce the words correctly and you will come out looking much better, I guarantee you. Now, what occurs in why do patients have photopsia? Now, the retina does not feel pain. So, if you any disturbance of the retina gives off a flash of light. Your retina is neural tissue. It's brain tissue. And so, I don't know if you all, well, you probably don't read comic books now because you're all into, I don't know, manga, I don't know. But when somebody, oh, I used to read these comic books, and when you get a punch to your eye, you see the comic illustration showing stars. And that is what that is all about. Because when you get any kind of eye trauma, for example, severe enough to disturb the retina, it gives off a flash of light. So when you have traction on the retina is being pulled, it gives off a flash of light. If you develop a retinal tear, it gives off a flash of light. So whenever a patient comes in and says they are seeing flashes of light in their eye, think retina. You had your history taken already, everybody? Anybody answer? Anybody? Did you have a lecture on ophthalmic history? Are there? Because you should. It's one of the first things you should have had.
Let's talk. Let's talk.
Oh, y'all don't want to answer because you don't want me to ask you questions. So you're quite aware of what photopsia is, yes?
Yes, Doc.
Oh, yes, yes, yes. Okay, so I don't know what to do next time. So whenever a patient comes in and says they're seeing a flash of light, you want to look retina. You want to think retina because you may be having retinal problems. Okay? Now, yeah, sickle cell retinopathy is going to cause decreased vision. And that decreased vision is going to be secondary to a vitreous hemorrhage or a retinal detachment, or you can also get macular edema, or if there's capillary non-perfusion involving the macula. So remember, our macula is our holy grail. You bow down and you say, bow holy macula, because any disturbance, any damage to your macula, you're going to get visual disturbance. You had your lecture this morning on diabetic retinopathy, and I'm sure doctor who did the lecture must have shown you when we do laser, and you leave your macula laser free, because if you laser the macula, then that's it. Okay, all your photoreceptors were gone. So you can laser all around the periphery, but you want to leave your fovea intact for the most part. And so patients who have macular edema, the rest of the retina may be perfectly normal in appearance, but their vision is significantly impaired when there's any damage or any insult at all to your macula. All right, so how do we diagnose these patients? Well, they got to have a history of sickle cell disease, obviously. So depending on what they're coming in with, if you get your history because you're going to ask them about sickle cell disease and you're going to examine them to look for these common shape. And so you're going to examine. It's really a diagnosis of examining. As I mentioned before, our fluorescein angiography, which examines blood flow, and we also do OCT, looking at the macula as well to see if there's macular edema and so on. So it's a special photograph that's taken by what we call an optical coherence tomograph. Now, this slide on differential diagnosis, I don't want you to study it. I don't want you to remember it. The reason I put this slide in is just to show a little snippet of all the things that are associated with vascular occlusion, with proliferation, abnormal vascular proliferations, and so on in the retina. So this is just to illustrate all, some of the things, not all, some of the things. And topping the list is our diabetic retinopathy, or diabetic retinopathy, or hypertensive retinopathy, okay, or vascular embolization, or retinal vascular occlusion. Same slide I showed you, where I showed you central retinal vein occlusion, where we had hemorrhages in all quadrants there. That's also a differential for sickle cell retinopathy. If you remember, I'll just show you again. So this is central retinal vein occlusion. And so this is also a differential of our sickle cell disease. And so the list goes on. But I don't expect you to remember this. I certainly would not be asking you to give me a differential for sickle cell disease, but you actually should be aware of this, because the pathophysiology of a lot of these conditions kind of follow the same route. Because you have new vessels come about when you have ischemia and so on. So don't kind of wear blinkers and forget about one thing when you're learning the other. So you're learning diabetes and you hear about retinopathy, and don't think it is too different in terms of the pathophysiology from sickle cell, because although it is a different systemic disease, the insult to the retina is more or less the same, but sometimes the location of where you have the primary lesions may be a little bit different, okay? So what's the goal? The goal of treating these patients really is to prevent ischemia as best as we can, to prevent infarction and all the complications of neovascularization. So we don't want that to happen, because when we get this happening, we're chasing our tail. So what screening is important. Prevention is the best form of treatment. So patients who have SC disease should be referred to an ophthalmologist for a dilated fundus exam starting at about age 9. So you start very young. Now, your SS and sickle beta thal may begin a little bit later, but not too later. And thereafter, we examine every year if there's no evidence of retinopathy. Now, all patients who present with a high FEMA should be screened for sickle cell. And as a matter of fact, this is how we pick up a lot of our SAS patients, sorry, because some of these patients who have the trait, they are totally unaware. They come into hospital with a high FEMA, and so we want to see what their status is. Because one of the complications of a high FEMA is increased intraocular pressure. And one of the ways that we use to treat some of the very high intraocular pressures that may occur is with acetazolamide, and that can lead you into painful crises. And it has actually happened where a patient came with a high fever, started on acetazolamide because of high intraocular pressure, and the patient, it precipitated a crisis, a painful crisis to the patient. So it's very important. That's part of our routine in this part of the world. You come in with a high fever, we're going to do your sickle test. Now, as far as the high fever is concerned, and I mention it because although it is not a retinopathy as such, but it's a very important um, complication and problem for our sickle cell patients. So I want to mention it because, as I said before, you're going to meet hyphemia when I talk about trauma. Um, but you're hearing it today. I'm going to meet you again on Friday when we go into a little bit more detail on hyphemia. But as it speaks to sickle cell, um, it because of the complication of a hyphema, even with a very mildly elevated intraocular pressure, patients can end up with optic atrophy, central retinal artery occlusion. And so we don't want the intraocular pressure to exceed 25 millimeters of mercury for over 24 hours. As a matter of fact, we say the 24-24 rule, not the 25-24, the 24-24 rule. So intraocular of 24 for 24 hours, we have a low threshold to do an anterior chamber washout. That's what I say mean here when I talk about the anterior chamber paracentesis. We want to wash out that blood. We want to wash out all those sickle cells because the optic nerve of sicklers, both the SS and the SC patients, very, very susceptible to high intraocular pressures, and they end up with optic atrophy very, very quickly if that intraocular pressure remains high for a long time. So we treat hyphemas slightly differently when we know the patient is whether it be sickle trait or sickle cell disease because of the very sensitive optic nerve and the way they end up with extremely poor vision due to optic atrophy. Now, non-proliferative sickle retinopathy, we have no specific treatment. We do nothing about the salmon patch hemorrhages. We do nothing about the black sunburst because those lesions are in the far periphery. They do not threaten vision, so we leave them alone. Now, when we see patients with a CFAN, we want to treat it. It's recommended that we treat the CFAN lesions in all the SC patients and in SS patients below 40 years. And I added this about SS patients below 40 years because, in truth, we tend not to see a lot of CFANs in patients who are SS. Because, as I said before, the SS patients, they tend not to have much retinopathy. It's kind of rare. Um, yeah, it's really uncommon. We rarely see it in our SC patients. And so we do laser photocoagulation um, and we do a sectoral laser in the region of the CFAN. We can do focal, we can do scatter, or we can do peripheral circumferential scatter laser, depending on what we see. So we treat the peripheral retina when we see these CFAN and new vessel lesions because these new vessel lesions will rupture, they will bleed, and cause a vitreous hemorrhage. Okay? Now, intravitreal injection, and again, you met intravitreal injection. You must have met it when we spoke about when you had the lecture on diabetinopathy because it's the same thing. You have new vessels, you have VEGF, and you want VEGF to regress. And so we use Avastin or whatever anti-VEGF agent. We're going to give it to them because it causes decreased levels of your VEGF and regression of your neovascularization. So when we do PRP, what we're doing, we're decreasing the oxygen demand of the retina because we're ablating the abnormal areas. We're ablating the areas where you have the CFAN so that the new vessels can regress. And also, our Avastin or other agents will cause regression of the new vessels. And surgically, we want to do surgery for a non-clearant vitreous hemorrhage. And I have here non-clearant vitreous hemorrhage because a vitreous hemorrhage usually clears. So it doesn't matter how large. I've seen patients where you cannot see anything at all in the retina. You cannot make out anything. It's like you have a glass of ketchup, about ketchup in a glass, and you can see absolutely nothing. And so it usually absorbs and the bleeding completely disappears. I've had patients where within about 4 to 6 weeks, you see absolutely nothing. And so you give it the opportunity to clear. Now, if the hemorrhage is non-clearing, you want to do a vitrectomy. You want to remove that non-clearing vitreous hemorrhage. Okay? And you usually give it whenever you have um, one eye that's affected. So you have a patient with a hemorrhage in one eye and the other eye is normal and they have essentially normal vision in the other eye. You give it about 3 months for the hemorrhage to clear. You don't rush into the vitreous hemorrhage. However, if you have a patient with one seeing eye, in other words, the better eye is the eye with the vitreous hemorrhage, then you want to go in sooner. You don't sit down for the 3 months because you want to intervene a little bit sooner because it's the only eye, the seeing eye of the patient. Now, for tractional and regmatogenous, as I said before, regmatogenous means the retinal detachment is due to a tear in the retina. You're going to do scleral buckling or whatever type of surgery, vitrectomy, whatever type of surgery is necessary. Oh, actually, scleral buckling is not too recommended for our sickle patients. We tend to do vitrectomy. I won't go into that because you can put that buckle around the eye and cause ischemia. So we tend not to do scleral buckling as we would do in other retinal detachment cases. So we probably do more vitrectomies and so on in our retinal detachment patients and also patients who develop epiretinal membranes. These membranes are membranes that develop because of the gliosis and so on from the bleeding that takes place with a vitreous hemorrhage. So that's what we do for these patients. Um, Now, that's what we do. So in summary, I kind of made a very short summary because I didn't go into everything. I just wanted to remind you that our sickle cell trait, patients essentially normal, tend not to have any retinopathy at all, and they have signs of decompensation only in very stressful circumstances. Our SS patients is the most severe form of the disease, but retinopathy in our sickle cell disease patients are uncommon. Our hemoglobin C, they have very mild anemia, but they have severe ocular manifestations. And in our sickle beta thal patients, it's a mild anemia, but they too get severe ocular disease. And that pretty much sums up what we want to say about sickle cell disease. As I said, it really was a reminder with just some information on the ocular manifestations. So I was not interrupted because I know you know all about sickle cell disease and all about the genetics of sickle cell disease. The only new thing that you learned today was some of the ocular manifestations. And when you learn about these new manifestations, you kind of scratch your head because it's kind of to or diabetic retinopathy that you heard about this morning. So, any questions? Or you were playing Japanese manga. So, because you have no questions, I'm going to make sure that I have questions for you next time we meet. So that I'll take a screenshot of who is in attendance and I will call on you all. How's that? Nobody, nobody answering? Yes, people. How is that? If I call on you all next time around. Everybody happy with that? No answer?